I did want to sort of make note of how much ground was actually covered in those last few talks. First of all, we discussed surveillance for resistance in viruses, bacteria, and parasites transmitted through vector, respiratory, and sexual routes. There were also some common themes that emerged, at least to me. First of all, there was a lot of attention paid to detection of geographic heterogeneity in resistance, some common themes about using classification schemes versus estimation schemes to document resistance. The question of how you properly link detection of resistance to policy change and use surveillance to contain resistance also played a large role here. So please, questions? Great.
Hi, my name is Helen Cox. I'm from Médecins Sans Frontières. Thank you for all the presenters. That was a very good session. I have a question or a comment about to Bethany about the system of classification. You're using proportions of TB cases that are resistant as the sort of central measure, and I would like to ask about why there isn't a sort of a population element into that. In that, well, I'm working in South Africa, and in our setting we have a 5% prevalence of MDR, but that actually equates to a population incidence that is higher than the Russian Federation and higher than most of the former Soviet Union countries. So in terms of having to respond to an epidemic, I think they're really, in terms of policy of how you interpret your classification scheme, there needs to be an element of population in there. For example, we can test 100 people in 1 week in our clinic to do your sample size because it's, there's so much TB. That's my question.
Thanks for your question. And to respond to that, I think what we're realizing is, for simplicity, having a global strategy for surveillance makes a lot of sense. You can develop guidelines, you can do training, you can provide technical support externally. But what we're finding in our pre-analysis or reanalysis of this data and the first pass at trying to identify a system is that for MDR-TB surveillance, there was no single system that worked universally across countries. And so what we're now, as a second step, trying to think through is, well, what structures would work and what needs to be variable country by country. And so certainly what would work for your region in South Africa would probably be very different than what would work for Ukraine and very different even for other countries in the region. So, it's trying to balance the providing technical guidelines universally versus adapting for countries. And I'm certainly happy to talk with you more specifically about South Africa and what might work there. Ted, I don't know if you want to add to that.
Sure. So I fully appreciate that the policy about what you do to react to an MDR epidemic might depend very much on incidence and not on proportion of cases. I would note that whenever you're going to do sampling, whenever you can't test all cases for resistance, the current policy comes out, you have large sample sizes to try to come up with a precise estimate at the country level. So I think LQAS has an ability to complement that type of approach by providing similar information at a finer geographic scale. And that can be, you can back into estimates of incidence if you have some idea of underlying burden of disease and you believe that whatever sampling you're doing at that particular level is representative. So, but I agree that the policy about how you'd react to that information might depend very much on incidence. So I think it's a good point.
Hi, Caroline Bucky from CCDD. I wanted to ask a bit about the dynamics of the spatial heterogeneity that you're seeing. I noticed that in Caliphie, the SP resistance has gone up, but transmission has really dropped over that time period. And so I guess for a lot of you it's relevant, the relationship between spatial heterogeneity and transmission intensity is going to be quite complicated because it's obviously going to affect the immunological background of the host, drug treatment, and how much disease there is, and also the dynamics. So migration is important, but there's also these very local scales of transmission, and I wondered if you could talk a bit about that.
I think you're right. It's sort of a complex relationship, and I think it probably feeds into the emergence as well. Maybe that in countries where there's really low, or in settings where transmission is relatively low, there's much greater selection pressure because people are less immune. A greater proportion of infections are treated, so the coverage translates into a stronger selection pressure, and it's very much more. It may explain the sort of more rapid emergence of multi-drug resistant malaria in Southeast Asia, for example. I think at the moment in Africa, what we're seeing is this sort of set of subpopulations which are very well interconnected by migration. And until transmission drops considerably lower, we will continue to see that sort of connectivity. As hopefully sort of transmission intensity is reduced, we should start to see islands and a lesser degree of interconnectedness. But I think that's quite a long way ahead.
No, do you see any relationship between the types of mutation, single, double? So it's quite obviously patchy, but I don't know, that might be a recent thing, and eventually the ones in the east will spread west. Do you see any relationship between local transmission intensity and the types of mutation that you're seeing?
Yeah, there's a lot of, I mean, I sort of, just to unpack that, yeah, we do see it, the emergence of additional mutations in low transmission settings, like highland settings. We've reported the emergence of a DHFR mutation called 164, which is actually, until recently, not been present in Africa, but it confers an even higher degree of resistance. And we see that in highland areas in Rwanda and southwest Uganda. So yeah, very much sort of looking to a sort of higher rate of emergence in Africa. But historically, those double mutants that I talked about, the ones that confer partial resistance, they're not converting to triple mutants. The triple mutants all originate in Asia. The locally originated double mutants are sort of trundling along. They're not increasing. After the sensitives are removed, they also start to dwindle. But it's all about the Asian originated triple mutants in terms of clinical efficacy and the sort of dynamics of pressure, and first line drug pressure is really pushing those. Tim, did you want to add anything?
So I find the data you presented and the argument about the heritability of artemisinin clearance rate to be very convincing, and it strongly suggests that there's a parasite genetic basis for kind of the clearance rate phenotype. But I'm wondering if you've thought, or what kind of possible alternative explanations that you've managed to kind of rule out that might explain that kind of phenotype as well, that may not have to do with parasite genetics?
I'm afraid I didn't hear very much of that question.
Okay, sorry. I'll try to speak more to the mic. So the clearance rate data that you showed and the heritability suggests that there's a parasite genetic basis for the clearance rate phenotype. I'm just wondering, because it's an in vivo phenotype, there might be other kind of confounding factors from the host. What kinds of other explanations you managed to rule out? I can't really think of any. Other kinds of, I guess, artifactual reasons why there might be a lot of correlation between clonally identical parasites that don't have to do with the parasite genetics?
I think that's the most parsimonious explanation. I think you could possibly make a slightly convoluted case that there could be epigenetic effects, but from the literature that I've seen, epigenetic effects will be maintained far less long than genetic effects. So I think it really is the only viable explanation for that data.
I just have a question about that 5% cutoff for gonorrhea. You said it's a historical cutoff, and I was wondering, if you're planning on maintaining that same policy with this new class of drugs, and if so, why? It seems that the rates of resistance resistance increasing aren't affected at all by policy change, and I'm wondering if you think maybe it should be lower or if it should be higher, and why?
So my understanding about the 5% threshold is that there's some data and there's a lot of hand waving. But it also came about at a time when we had a lot of treatment options. So there were, I don't know, there were many treatment options which had at least 95% efficacy. We had multiple ones that had 98% efficacy and greater. So, and as you allude to, we don't really have that luxury anymore. So I think, yes, I am one who is in favor of readdressing that threshold because if you look at our current treatment recommendations, it gets even more stringent than that, in which a drug to be recommended for treatment not only has to have a 95% or higher treatment efficacy, but also has to have a lower bound of its confidence intervals to be 95% or greater. I think especially with with our current lack of well-studied treatments, I think we definitely need to address that. I think what we're looking at is a future of hopefully there will be new drugs that will be developed, but Neisseria gonorrhea is not going to be a blockbuster market share for a lot of pharmaceutical drugs. So I think trying to repurpose existing drugs too, and perhaps in combination, and perhaps allowing a lower threshold may be the way to go. I think it's something that certainly to be discussed. Lower threshold for treatment efficacy.
I think we have time for one more question.
Thanks, Ted. I was actually going to suggest a couple of things to Tim, which, I loved your talk, by the way. I thought it was great. But a couple of things that I was wondering about that could maybe have created an effect would be things like host genetics and co-infections. And if you were to, say, find genetically identical parasites in members of the same family, then you might think that host genetics could have something to do with it. Or indeed, co-infections, which we know can have influences on parasitemia. So, I have no idea whether or not your identical parasites came from widely disparate people, but I wondered if you could comment on that.
So, yes, certainly host genetics would be an alternative explanation. In a number of those genetically identical patients, we followed them up to see whether they're family members or whether they're from the same village. And in most cases, we found they were from the same kind of places, but they were in different families. So again, I think that's a fairly tenuous explanation.
Great. Well,
in a way, it's a lot tighter data than human twin studies, in that you essentially have twins that are reared apart. Yeah.
Okay, can you join me in thanking the speakers, please?